All right, just hoping my sound is a little bit better. Hopefully the panel is saying good. I move it as close as I can. Here we go. Just wanted to thank everybody for joining us today. If you're looking for these skills for psychological recovery, supervisor orientation, you're at the right place. And we just wanted to share, as you probably know, that it's being recorded. You are muted because it is a large group. And we will go over some logistical things in the slides ahead, but I'm just going to go through a few brief slides about our center and then turn it over to our presenters. So this is the supervisor orientation. If you have not heard of SPR before, that will go over that in detail. The Northwest MHTTC is part of a national network of technical and training centers. And so we are here in the corner up here from the University of Washington, and that's where I'm speaking from today in Seattle. About our Northwest Center, we are primarily targeting the behavioral health workforce and folks who are serving people with serious mental health issues, covering Alaska, Idaho, Oregon, and Washington. Our goals are essentially to accelerate the adoption of best practices, heighten the awareness, knowledge, and skills of the workforce, foster alliances amongst our community members, and ensure the availability and delivery of publicly available free of charge training. So all the trainings and webinars and things you see are all supported by SAMHSA, so that's how we can do what we do. And what we do includes a variety of things. So live training such as this, we usually record and archive all the webinars, and those are on our website. We have a website with events, products, and news. And so we also share information from other training centers. We also have some online asynchronous free courses that you can take at your own pace. And we also produce research and practice briefs on various topics as well as other things. Lastly, this is supported by SAMHSA, and so SAMHSA is not endorsing the opinions expressed herein, but we just share this, but know that our expertise is excellent today. We would like to speak a little bit about language, and so this is mostly common with everyone in our field, but just thinking that, having affirming, respectful, and person-first language is really strengths-based and hopeful, respectful, and, is not focusing on labels. And then also thinking about language, if this is going to be recorded, and so please don't share identifying information if you bring up a particular case or situation from your employment. Now on to some of the logistics. So there'll be a chat box, and that is where we'll share some things that maybe you need to know. We'll send you a link shortly where you can find the slides that are available already. You can let us know if you're having any tech issues. So from you can send it to us as the panelists, but you can't chat with each other, but we can chat with either individual or the group as a whole. But chat box is ideally not for content questions, and I'll explain why next, because we're also using the Q&A option here. So you can raise your hand as described at the bottom, or you can type in a question in the Q&A box. And so someone from the panelist team will be monitoring for that and make sure we have time for questions before we wrap up. After today's session, I will just plead. The one thing that SAMHSA really, really appreciates is if we can get a small, short survey from you that really helps our team plan future sessions, allows us to provide these things free of charge, and helps us evaluate our center's work. Just a reminder as well, there aren't certificates or CEUs for this series, but we do have the slides available. Those will be posted in the chat shortly, and we will have any resources mentioned on an event page at the end of the session within a week or so. And now our presenters, I'm very happy and grateful to introduce our presenters from the University of Washington Trauma Recovery Innovations Program within the UW Department of Psychiatry and Behavioral Sciences. They have a lot of content, so I will turn it over to them.
Thank you, Christina. I'm just going to share my screen. Okay. My name is Emily Dworkin. I'm an acting assistant professor at the University of Washington School of Medicine, and I'm one of the core faculty in the Trauma Recovery Innovations program. And I'm joined by my colleagues, Dr. Michelle Bedard-Gilligan and Dr. Kristen Lindgren, who are the co-directors of the Trauma Recovery Innovations program. And we are so excited to join you today to give an orientation for supervisors about SPR with some added content for those supervisors who have staff who are joining us in our Learning Collaborative. So before we begin, I just wanted to acknowledge that Skills for Psychological Recovery, that I'm going to be using the acronym SPR for, is adapted from the field guide developed by the National Center for PTSD and the National Child Traumatic Stress Network. And that field guide is freely available online. And we just wanted to especially thank the team at the Northwest MHTTC and SAMHSA for their support of this work. So we're going to do this in two parts. So the first part is going to be about 20 to 25 minutes, a little shorter than we have on this slide. And it's going to be essentially a bird's eye view of how you would implement SPR in clinics. And what we're not going to be doing in this webinar is telling you exactly how to deliver SPR itself, because we covered that in our SPR webinar for providers, which you are still able to access. It was recorded and it's available to you if you want it. What we're intending to do here is give you some food for thought in terms of, in your role as a supervisor at the clinical level, what do you want to be thinking about to support staff who are implementing SPR? So that's going to be the first part, and I'm going to be doing that part. And then I'm going to turn it over to Dr. Lindgren, who is going to talk about about some of the considerations for the Learning Collaborative kickoff. So for those of you who have a staff member who's participating in our Learning Collaborative, this second part is especially for you. So we will ask you to stay for part 2 if you have a staff member who's participating. But if you are from Region 10, so Alaska, Idaho, Oregon, or Washington, and you think you might have a staff member who might be interested in joining the Learning Collaborative, we invite you to also stay for part 2 to learn more about it. And please send a chat to the panelists with that staff member's contact information so we can give them an invitation to join our Learning Collaborative. So again, first part, overview for everybody, and then we are going to just ask those people involved in the Learning Collaborative or who hope to be involved to stay for part 2. And just a reminder, I know we already said this, but please direct your content-related questions that you want us to answer in the presentation into the Q&A box and save the technical questions for the chat box. Okay, so I'm going to get started by talking a little bit about crisis, resilience, and skills for psychological recovery, or SPR. So when we are facing a crisis like COVID, our primary task is to promote resilience in those around us, including our clients and our staff and ourselves. And one of the things that we want to emphasize in this presentation is that resilience is not uncommon or abnormal. It's actually the most common outcome of a crisis. So we expect most people following COVID to actually be resilient. We don't expect most people to develop long-term mental health problems. But at the same time, resilience is not a perfect straight line. It can be variable and it can be nonlinear. So just because you're resilient doesn't mean that you don't experience any distress. So this means if you're experiencing distress, it doesn't mean that you're not going to be resilient. And in fact, what we expect to see in most people is periods of distress followed by periods of lower distress, and over time, this pattern of those peaks going down and getting to a place over time of lower distress, kind of back to baseline. And resilience is a skill, so it can be acquired and learned. It's not just something that people either have or don't have. So when we're thinking about what to do for our clients and our staff and ourselves in the midst of a crisis like COVID, what we want to think about is how do we facilitate this resilience? Because again, it's not something that people either have or don't have. It's something that we can help people to have. So skills for psychological recovery, or SPR, is a resilience intervention, meaning it's a type of program that's focused on building resilience. And this is reflected in the goals of SPR, which include protecting mental health, enhancing your ability to address your own needs, teaching skills to promote recovery, and also preventing maladaptive behaviors such as ineffective coping strategies or harmful coping strategies. SPR is flexible, so that means that it is tailored towards the clients that are presenting in front of you. And it's also what we call evidence-informed. So you may have heard the term evidence-based treatment. So this is a type of treatment that has been tested in a lot of randomized clinical trials and is found to help people more than some alternative. And in contrast to that, SPR is evidence-informed because it's very, very hard to do one of those types of trials for a program that's delivered only when a crisis happens. So it's hard to have that all set up and then just sit and wait for a crisis to happen so you can test it. So what this means is that SPR is based on things that we know work for people that are experiencing high levels of stress or people that are experiencing trauma. And so we have a lot of evidence from other studies and from theory that it should work, but SPR itself has not been tested in the rigorous clinical trials that would make it an evidence-based therapy. So SPR's principles and techniques are, like I said, based on research on trauma and risk and resilience. They're something that can be applied and to a variety of settings and can be practical in a variety of settings. It is appropriate for people and families across the lifespan, and it is culturally aware in that it can be tailored towards the needs of people presenting you at intersections of various identities. But the SPR manual and field guide also has some kind of food for thought around cultural adaptations of SPR. So when you do SPR, and again, we got into more of the nuts and bolts of this in our provider webinar, but just to kind of give you a sense of how it looks from a bird's eye view, it begins with assessment of presenting needs and concerns. There's a collaborative process of understanding what a client's top priorities are and then working together to make an action plan rather than imposing a plan upon a client. It includes 5 individually tailored skills modules. So each of these 5 skills can be selected or not selected based on the needs of the particular client. So this includes building problem-solving skills. It includes promoting positive activities, which is very similar to behavioral activation, if you're familiar with that. It includes skills around managing intense reactions to trauma or stress. It includes skills around promoting helpful thinking, which is similar to cognitive therapy. And then finally, it has skills related to rebuilding healthy social connections. So evaluating your social support and thinking about where you need to grow and how to accomplish that. The course of SPR, so how it's delivered, is both flexible and structured. So it's delivered in a short-term way, so usually in a minimum of 1 and about a maximum of 5 sessions based on the needs of the particular client. And sessions typically last 45 to 60 minutes. The first session involves introduction, so orientation to both SPR and the client and the provider. Then there's an assessment and planning process, like I mentioned. And then you, in the first session, teach and practice one of those 5 skills that I mentioned. And then in the following sessions, you would review the homework that was assigned from the first session, because homework is one of the critical parts of SPR. And then you reassess clients' needs and then teach and practice a skill, which can be the same as the first skill or a different skill, depending on what a client needs. So some food for thought in identifying clients. So when you're thinking about who you might or who your clinic might consider for getting SPR. This can include new clients that are presenting either during or following a stressor. So I imagine many of you have clients that are coming and saying that they're dealing with COVID-related stresses and needing support. So this would be ideal for those sorts of clients. This can also be appropriate for existing patients that are being seen for other purposes, but who need some sort of extra structured support and maybe for help getting through the current crisis. This could be patients that are being seen for something unrelated to mental health. So med management patients, clients being seen for physical health concerns that you're finding are needing behavioral support. This can be for former patients needing boosters and also for consult patients in non-specialty clinics. So for each of these client groups, what I would encourage you to think about if you're thinking about offering SPR is what you might need to do to make it known to these various client groups that SPR is available to them, and what the channels for referral might be. And we'll talk about that more in depth when we get into the Learning Collaborative for those of you that are staying for that component. But for those of you who aren't participating in the Learning Collaborative and are planning to offer SPR, just thinking about facilitating clients' entry into SPR via a variety of routes can be helpful. We also want to point out that SPR is appropriate for many, but it's not appropriate for every single client that you might see. So it is appropriate for people in the chronic phases of a crisis. So this is in contrast to something like psychological first aid, which is meant for people that are kind of in the midst of a crisis. This is more for people that have passed that immediate kind of intense, overwhelming crisis phase. This is not appropriate for people who are a danger to themselves or others, or for people who are acutely psychotic or severely cognitively disabled, because these kinds of client or patient groups might be more appropriate for a more intensive or more tailored treatment to their needs. It also is appropriate for people with comorbid conditions. So just because a patient has, severe PTSD or severe depression or severe anxiety does not mean that they can't benefit from SPR. So I would encourage you to still consider SPR even for your clients or patients that are being seen for another mental health concern. This is not for patients that have immediate needs around their safety, like for example, establishing housing. That would be the main priority to take care of before doing a behavioral health intervention. It's also not appropriate for people that are having an acute onset of a mental health disorder or some sort of physical health condition, because again, attending to kind of the immediate needs around those conditions is likely more pressing than dealing with the chronic effects of stress or a crisis. Okay, so we have some food for thought for implementation that I will discuss next. So one of the things that we wanted to have you think through when thinking about implementing SPR is that there is pretty low uptake of evidence-based treatments among therapists. And so I think it can be useful to think about what some of the barriers to implementing evidence-based or evidence-informed treatments might be, and what makes these treatments worth implementing even in light of those barriers, and then how those barriers might be able to be addressed. So there's many barriers at the level of patients, and I've certainly experienced this as a therapist who does evidence-based treatments. So some of our patients, actually most of our patients, right, are usually pretty complicated. It's pretty rare to encounter somebody who just has a new onset mental disorder and they don't have any other conditions or any other life stresses. And I think that's especially true right now, that people have mental health conditions and they're experiencing stress or crisis related to COVID or anti-Black racism or other things that are going on in outside of their mental health condition. It can also be things like, sometimes it's hard for patients to be able to come to sessions, and there might be barriers related to reimbursement for sessions from their insurance that make it possible to do an evidence-based treatment, which is, in the case of SPR, 1 to 5 sessions, but in other treatments up to 12. Sometimes there can be issues with patient buy-in that are important to consider. So it's important to think about how you're explaining these treatment alternatives to patients, and what you're framing as the advantages and downsides to doing treatments like this. There's also clinic level barriers. So in some clinics, there can be, therapists might feel that they need on-site supervision, and sometimes not every clinic has that. There can also be barriers like, a need for ongoing support from trainers that are certified in doing the treatment, which is not always available. And these are some of the things that we were hoping that this learning collaborative would address, is giving people some sort of ongoing support about implementing SPR. And then at the clinic level, many clinics also don't make evidence-based treatments part of their sort of standard practice. And again, there are many valid reasons for this. So this can be barriers among therapists. So, you train therapists in doing these evidence-based treatments, and it takes a lot of resources to do that. But then, maybe those therapists leave, and it's hard to kind of make that a continuing option. Also, there can be a lack of buy-in among therapists. We all have our sort of strong adherence to various treatment approaches, and it can be really hard to learn something new when you've been trained a different way, and so that can get in the way. There can also be clinic barriers. I think resources are scarce right now, and there can be a lack of time to pay for trainings, or there could be a lack of money to pay for trainings, time to train people. Providers are stretched really thin, wait lists are very long. It can be hard to implement at the level of the clinic. And then the treatments themselves can also impose barriers. So these treatments can be expensive to get training in. Sometimes they're proprietary. Sometimes they require you to buy materials that are not cheap. And so I think thinking through these things and which of them would be relevant at your clinic for SPR, I think is an important first step in getting started with these things. And then it's also important to talk about treatment fidelity. So this means kind of adhering to the treatment as it was designed to be delivered. And sometimes that can be low in practice too. And one of our goals for this learning collaborative is helping people deliver these treatments the way that they were designed to be implemented, while of course allowing flexibility for patient or client concerns. So some factors that can get in the way of delivering treatment fidelity, and again, as somebody that does these treatments, I have certainly experienced these barriers. This can be patient barriers. So if you're trying to do a manualized treatment and every week there's sort of a different fire to put out, that can get in the way of doing the treatment. Sometimes, there's barriers in the clinic in terms of how many times you can see a patient or for how long you can see that patient that might conflict with what the treatment is saying that you need to do. And then also just, doing a treatment as it's designed takes a lot of time and resources and even just brain bandwidth. And I think that can be really hard and difficult to do without enough supervision. So we want to make the case that evidence-based treatments and evidence-informed treatments like SPR are worth the investment. So what we tend to see with a lot of evidence-based treatments, and I'm not going to say this is, across the board for every single one, is that we get really good patient outcomes for these treatments in a short period of time. So I think even if we make the case that hypothetically, even if the outcomes were equal to evidence-based treatments and other treatments, I think what we want to do is be most efficient with our use of therapist time and clinic resources and also clients' time. So if it's an equal choice between two options and one option gets you the same place in a shorter amount of time, I think that is an advantage of a lot of evidence-based treatments. Also, I think we're all experiencing that clients and patients are showing up asking for certain evidence-based treatments, and having therapists that are trained in delivering those treatments means that clinics are able to be responsive to the requests and desires of the communities that they're serving. So, I think for me, these are the factors that make evidence-based treatments and evidence-informed treatments worth the barriers, or worth addressing the barriers, and worth the time and resource investment. And that will look different for every clinic and every supervisor, but we just wanted to give you that sort of general food for thought in thinking about how to move forward for this. So to adopt a new approach like SPR, we have to work through the barriers that I talked about. And so before we switch over to talking about the Learning Collaborative, I want to just pose some questions to you to think about as you think about how to implement this in your clinic. So what do you think it would take for therapists or clinicians in your setting to try SPR? What would their concerns be? What would sort of convince them that this is something that's worth trying? And what barriers at the level of patients or providers or at the clinic would potentially get in the way of their ability to conduct SPR in the way that I described earlier? And then finally, what can you do as supervisors to facilitate therapists' learning and practice of SPR? So again, just some food for thought, and I hope these sort of stimulate some great ideas in terms of how you can implement this in your clinic. So with that, I am going to pause. I'm going to turn it back over to Christina briefly. And then we are going to switch to the part where we're talking to the people who are either supervising people on the Learning Collaborative or interested in their therapists joining the Learning Collaborative.
Emily, this is Michelle. I hope you can hear me. Did you want to take one quick question before we turn it over to Christina? We had a question about if you could speak to greater barriers for individuals who might have dual diagnoses compared to just one diagnosis and how they might think through that. And if anyone else has any questions, please do feel free to put them in the Q&A function. I'm happy to either field them or pass them on to the speakers.
Thank you so much for the cue to check for questions before we move forward. And I also would welcome either you, Michelle, or Kristen to chime in on this one. But I think that the nice thing about SPR is it's a general set of skills that can be adapted to the needs of a client that's presenting in front of you. And they tend to be skills that are best practices for addressing a lot of different conditions, including substance use disorders and PTSD and depression and anxiety. And so they're adaptable to those different presenting problems. I think with a dual diagnosis patient, we might want to think through, is dealing with the chronic crisis the main concern, or is the mental health or substance use disorder more primary and needing more attention first? So would this take away time that they actually need to be spending on the substance use disorder or the mental health condition? Would we be kind of enabling avoidance of addressing those things by switching to something like SPR? Or could SPR actually facilitate their ability to make change in a behavioral or health condition or substance use disorder? And then finally, I would think about whether there are any safety concerns that might affect whether SPR would be a good idea in that moment. But Michelle or Kristen, feel free to chime in. Did I cover it? Wow, okay.
Yeah, I think so. If you have any, if the person asking the question had any other comments or questions, please feel free to type them in. I'm also happy to type back answers as well. And it looks like Christina just needs to share her screen, Emily, but we will turn it over to her for the next brief portion.
All right. Well, thank you so much. I hope you can hear me, and I will be sharing just a couple more slides and let them get back to it. I mentioned in the beginning that we really appreciate your feedback. And so what will be happening is during this time or at this time, there'll be a link put in the chat. So if you're not staying for the later part of the discussion, we really appreciate you taking just a few minutes to do just a quick online feedback survey. It is confidential. It only goes to our evaluation team in aggregate. And so want to make sure that evaluation link is posted here shortly into the chat. There it is. So it says red cap on it. That's the link. Thank you, Gabrielle. And so you'll look at a screen that has, this kind of purple on the side. It'll ask you for some sort of personal code that's based on some things that don't change in your life, generally speaking. So that's why they ask for those specific things, but they are not identifiable when it gets to SAMHSA. And you just follow the questions. It takes just a few minutes. We really, really appreciate your feedback. And then just also want to say, if you want to be in touch with us, and if you aren't already on our newsletter and getting announcements for training events like this, you can visit us online, see our newsletter, you can email us or follow us on social media. And I think that's all I have to say. So just thank you ahead of time, and we'll look forward to hearing more of the discussion. And thank you to all the presenters.
Thanks, Christina. And Emily, thanks for sharing your screen. I appreciate it. And so what we wanted to do now is for individuals who want to learn more about the Learning Collaborative that we're going to be kicking off formally in terms of activities in January. We want to let you know what that's going to be like, how that works. And those of you who are part of the Northwest region, if you are curious and think you might have any staff in your clinic who would be interested in implementing SPR and trying it out and joining with us as a way to learn this, you are absolutely welcome to hang in and join us. And similarly, those of you who might be outside the region but want to just kind of get a feel for, well, what might it look like to really support learning a new therapy like this in an intentional way? Perhaps there's some parts of this that might spur some ideas. We're absolutely delighted to have you stay on with us and see what this looks like, and maybe, again, might give you some food for thought. So Emily, if you would turn me to the next slide. Basically, how the Learning Collaborative is going to work is it's going to involve frontline providers who are treating clients and using SPR, and also myself and Michelle and Emily as partners in that process. And so we're going to be bringing together what we hope is the best of two worlds, the expertise that you and your staff as frontline providers have on what it's like to implement SPR in your specific community, with your specific clients coming in with their different identities, with their specific issues and concerns, and blending that with the experiences that we have from our roles as researchers and also clinicians on that way, and then bringing it together so that we can really, hopefully, to quote our boss, Michelle, Emily, and me, do a lot of good, and hopefully do a bunch of good for people who are really suffering right now. So how we're going to do that, I want to walk you through the different components of the Learning Collaborative. We're going to have 4 components to the collaborative. The first part is just some basic training in SPR, and that refers to a webinar that we did live back in November, but is available as a recording as well, that provides an overview of SPR, what it is, hopefully takes out the jargon. There's so much jargon in these different kinds of therapies in terms of how we talk about things and what the techniques are. We hosted an orientation last week. That's the second part for people who are going to be participating in the collaborative. And again, there for frontline providers who are going to be joining us with the collaborators, we also have a recording of that webinar as well, so that people can see and learn what that looks like. And then other components of it are consult calls. And that's really fancy terminology that we tend to use in the academic world about basically a way to provide some learning every other week, for us to provide some content that we can to really teach the different skills with SPR, and also give an opportunity for people to talk about what their experience is. Also built into the collaborative are check-ins and wrap-ups to see, as a group coming together as a full collective, what's going well, what are key lessons learned, and what can we do to make it better, and what can we do to improve SPR as an intervention to really benefit as many people as possible. So we want to dial in a little bit more to give you a feel for those frontline providers. So for staff who are going to be part of the Learning Collaborative and who are going to be implementing SPR, what we're going to be asking them to do is to start to identify potential clients who could benefit from SPR. And they can think about doing that in either on an individual level, so individual clients. And again, those clients could be kids, it could be adolescents, could be adults, could be older adults, or groups. And we're asking people to identify at least 2 individual clients, or people that would be part of a group that they would run. What we're asking people to do is to be doing everything they can so that they could start seeing those clients or groups in early January. We know that dropout is certainly a part of what happens with mental health care in general. And so we want to identify people as early as possible and get them started so that we can start addressing those barriers and find people that are a good fit and a good match. We're also asking people to find time to prepare for those sessions group and the consult calls, because we know that one of the barriers for implementing treatments is just actually being able to find the time to learn the treatment. So we're asking people to anticipate that they're going to need some time and to identify that time. And also to really think through the technology and the logistics, especially if they're doing groups. And so whether that's about doing some kind of telemedicine, like we're doing an online meeting today, whether there might be some version that happens in person, realizing there's a lot of variability in what this might look like. And also, like, how would we get materials? If we want people to practice a skill and we want to do a handout, what would that look like in the context of SPR? And so those are some of the things that we're asking people to start thinking ahead and think ahead to. What we're recommending that people do for those individuals that are going to be part of the learning collaborative, so for those frontline providers, that collaborative is going to go for 6 months. It's going to start in January and then wrap up in June. We're recommending that if people want to get maximal learning, that people work with 4 or more SPR individuals, clients, or lead at least 2 groups. And we understand this is an aspirational goal, that things are really complicated right now, but the more you can practice it, the better, in terms of really learning about what is unique to a specific group or a specific client versus what seems to generalize across lots of different people. And also, how do you really adapt the treatment as best as possible to meet needs in your specific communities? We also ask people, in terms of making the most of the collaborative, that when they come to the consultation calls, which will happen via Zoom, they'll be smaller, about 10 to 15 people in a group at a time, to really come prepared with their questions and their experiences to be able to share, so that it benefits everyone in the process, so that you benefit by not just presenting and getting feedback on your own case, but that you get this really rich learning experience by hearing about how this is working for other people who are taking part in the group. Similarly, we ask that people come and participate, and that they ask questions, and that if they're stuck or something goes really well, that they're presenting on that so that we can learn and share. So the way that we're going to be really digging in this deeper learning experience is through these consultation calls. Again, they're going to start up in January, and they're going to happen approximately twice a month. So every other week, we'll have a consultation call. Those calls will be on Zoom, just like we're doing today, and they'll be about 50 minutes. And they're going to have 3 components. The first component is some kind of mini lesson that Emily, Michelle, or I will prepare. We'll also dig deep. Second thing that we'll do is dig deep on 1 to 3 different members of the learning collaborative on their cases or their groups. What's going well? What are they learning? How did it go teaching this particular skill? And then at the end, we'll allocate time to have a Q&A and a discussion to really think through together and celebrate victories that have happened, and really do some more troubleshooting on challenges that other people are having that aren't, where we're not digging as deep on their cases. And we want to talk a little bit about why consultation is important, because this is something that may not typically be part of learning experiences. But when we think about it, it does a lot of different things. I think often the model of training that I was exposed to when I was doing my graduate training was a lot like this. You come in and you listen to a presentation, then it wasn't on Zoom, it would have been in person. And then you kind of go out and implement it, and realizing that that's only a very small part of the learning process. And in fact, that people being able to do the treatment well, people being able to stick with it, it's really hard to do it if what you do is only listen to these kinds of didactic presentations. And so consultation, where you're really being part of a group, getting additional learning and ways to really engage in the material, it really seems to increase uptake, and it really seems to make for better outcomes for our clients. And one of the things that it does that I think is really lovely is, if you think about it, you'll be part of, or your therapist will be part of, a community over a 6-month period. And so it really strengthens their own community and connections, where they're developing expertise and they've got people that they can continue to draw upon even after the collaborative is over. And it gives a lot more opportunity to practice, and really hones those kind of critical thinking skills, where you're having to engage with the material in a very effortful and intentional way on those 50-minute calls for that 6-month period. In terms of the consult call information, for those of you who have providers that are going to be joining us in part of the collaborative, or for those of you who think you might, our consult calls are going to take place over the course of the week. We ask people who are part of the collaborative to sign up for a single call, and they're going to stick with it over the 6-month period. And those calls happen on Mondays, Tuesdays, or Thursdays. The time that's there, to be really clear, that's Pacific time. That's the time zone that those are part of. That those calls will start the week of January 11th and wrap up the week of January 14th. What we're asking for people to do is to attend at least 9 of the calls. We'd love to have everybody every time, but we know that life happens. And we also For people who attend at least 9 calls, they will also receive a certificate of completion. And so what we've asked people to do, and what we're going to be asking people to do over the next week or so, is to identify a preferred consult time and sign up. Okay. And so when we think about at the clinic level, in terms of you as supervisors, and what are some things that you might do for your team members that might be part of the learning collaborative, in ways that you could really help meet their needs, is to really help think through and anticipate that they'll need space in their caseload in order to be able to see individuals who would be getting SPR, or time to be able to do the group sessions. Similarly, that they'll need some time in their calendar to be able to prepare for sessions. The first time you do something and it's new, you do need a little bit more time to prep. And so we want people to be anticipating that. And one of the things that you can do as supervisors is to really support learning on that standpoint, by giving people time to prepare so that they come in and they're ready to do it. Similarly, supplies, if people do need supplies, if there are materials that they need to get to clients. And again, that's going to be variable. They're not always going to need that. And so I think that's one of the things just to be thinking through with providers that you're supervising. Hey, do you need this? And if so, how are we going to make this work? And similarly, also time, making sure that people have the time and the availability to attend the consult call so that they're freed up to do that. Right. And then things that you can also do as you're thinking about this as a supervisor is really things you can do to promote the availability of SPR. The fact that you're going to have providers that are getting training and expertise in SPR, and that this is something that people could benefit from. Things that you could do is putting out a flyer, letting people know, hey, we're going to be starting a Skills for Psychological Recovery group, or hey, we're going to be looking for clients who are really interested in brief treatments to help facilitate resilience and get through this really stressful time. Giving a heads up to people who actually provide referrals that this is an option. If you do have a website, the fact that you might advertise it there, and to let people know at staff meetings that this is something that will be available and an additional option for clients that come to you. And with all of that, we want to close again just with saying how excited we are about being able to offer this learning collaborative, and really see this as a way for bidirectional learning, where we have some expertise, Emily, Michelle, and myself in SPR, that we're really excited to bring to your providers. And we're really excited to learn from them as well, and really think about what can we do to really reduce the suffering that so many people are experiencing right now, and what can we really do to build resilience. And with that, I'm going to stop here and see what kinds of questions are coming up, and also ask Michelle and Emily to come back on so that between the three of us, hopefully we can answer any issues.
Yep. Thank you,
Okay.
Kristen. So I know in the chat, we did put some additional information on who's eligible for the Learning Collaborative and how to follow up on that. So that is sort of listed in there as well. It does look like we have one question about an international participant participating in the Learning Collaborative. And I am going to let Christina or someone else chime in, but I believe that that is not allowed.
Correct. Yeah, we do need to serve Region 10 with this particular project. So Alaska, Oregon, Idaho, and Washington.
That's what I thought.
Yeah, because we're a regional center, regional training center. So some of our offerings are available all around, but these smaller projects, we are supposed to be regionally focused, I'm sorry to say.
Yeah. So thank you so much for your interest. I'm sorry we're not able to meet that and support that, but we really appreciate you being here and reaching out, and hopefully this might give you some ideas. Other questions that we can answer? I will let you know as well that there's some information that's coming out in the chat right now from Gabriel. Thank you so much, with information about if you have somebody that's part of your clinic, your staff, that you think might be interested in joining the collaborative, because we do have a few spots left for the collaborative that'll be starting up in January, that we'd be delighted to have you. And so there's some information in there about what you would do and how you would let us know about that. Other questions or concerns?
So it looks like we have one more question about additional opportunities for other regions to participate at a later date. Again, that's probably more of a question for our MHTC colleagues. I think the answer is not at this time, but I'm not sure, Christina.
No, I think, we try to offer the webinars. So this and part of it will be recorded, and the original SPR overview is recorded, and that is available to anyone, anywhere. So on our website, you can find our archived webinars, you can find the YouTube recordings for that. And then you all have done an amazing job of putting a lot of resource pages with a lot of the material. So we just captured a lot of what you've shared and put that on our website related to those events as well. So that's what we're able to offer. It's a tough balancing act. Everyone's virtual right now. And so the word gets out very easily now, but our mission as a regional center is to try and do these more intensive projects for our region. Because and if you didn't know, just as a reminder, you can also request your region's MHTTC to have this as an option. So their information is readily available, but if you just go to mhttc.org, you should be able to find whatever region is in your neck of the woods, and you can always request that they do something like this in that region, because we're all here to do the same thing. So that's the beautiful thing about it. And there's a ton of resources that they all record their webinars as well. So a lot of things are available to everybody, and then sometimes these smaller projects are more regional.
Great. Thank you, Christina. We appreciate that. There's a question here for Emily, Kristen, and I about having staff located in an educational setting and whether or not there will be time in the collaborative meetings to discuss cases and implementation for those who are educators and have maybe less formal training in the mental health field. My response to that would be yes, that we are interested in having individuals with varying degrees of training and expertise in mental health, and that one of the really great things about SPR is that it's something that is designed to be delivered even by non-mental health professionals, just by individuals who have some basic training and sort of providing support to individuals. But if there is room in their setting and within their role to do this kind of repeated intervention with someone, that this might be a place for that. Although I do see that Gabrielle is putting something in the chat about something that's more school focused. That could even be a better fit. But certainly I think this might be a fit as well. Emily and Kristen, I don't know what you want to say about that.
Yeah, I think the piece that I would add is that it would certainly be consistent with the idea that how is SPR adapted to be consistent with the culture and the environment that you're in your specific context. I think the flip side with that would be just to make sure that SPR fits within the bounds of the particular roles that you have, and that while you don't have to have specific advanced degree in mental health, as Michelle said, that there is some baseline training in mental health interventions and mental health concerns, just from the standpoint of being able to do SPR and implement the interventions. So I think the answer is yes, and just some caveats to make sure that those things would be a fit, but would be delighted to support learning in multiple contexts.
I think the one thing that I would add on top of the very wise points that my colleagues have made is thinking about issues of fit in terms of, SPR is a psychological intervention. It's different from something like psychological first aid that is, you can sort of deliver it, in a more kind of ad hoc way in a one-off interaction. It's supposed to be something that is in a 45 to 60 minute session, and there's multiple sessions like that. So whether that would be in the bounds of a given educator's role, I think just depends on the educator and their role, and sort of checking in about is this something that an educator would typically do with their students? And, might it be more appropriate in some cases to refer to somebody that's more set up to do kind of ongoing clinical sessions? While, of course, emphasizing the fact that SPR, part of the beauty of it is that it's meant to be delivered by people without advanced degrees in mental health.
Thanks, everybody. Additional questions that we can answer? I'll give another minute for people to think and chime in. And as we're doing that, I'll also remind you and alert you to Gabrielle's message about evaluations and how important it is to the MHTTC for their own funding to be able to say that we did this and to get feedback about what's effective, what's not effective, what's helpful to you, what's less helpful to you, what else would you like to see on that end. So to please take the time to do that. Similarly, we do have a few spaces left in the collaborative, and we'd be delighted to have some more people from Region 10, which is again, Idaho, Alaska, Oregon, and Washington, that if there are frontline mental health care workers that you know of who you think would be interested in this as a way to support their learning and be able to do SPR, we'd be delighted to have them. And again, you can reach out via the chat or reach out to the MHTTC team in Region 10 specifically and let them know. And with that, oh, maybe another question. I see a question about, are there any plans to do learning collaboratives for the crisis counseling programs in all 50 states set up to provide crisis services related to COVID distress? CCP has some different parameters from the counseling centers as it's all community-based. That's a question that's beyond the scope that Michelle, Emily, and I have in terms of doing the SPR learning collaborative. So I'll turn that over to Christina.
Sorry, just trying to get my question. I'm sorry, where was that in the chat?
It was in the Q&A.
Q&A, okay. So
I marked it as answered by accident, sorry.
Oh, no worries. Okay, oh, I just need to scroll down. Okay,
The very
thank
last
you.
one, yep.
You know, I will say, you know, so there are 10 regional centers and then 12 total, because there are 2 specialty centers. And so what I would recommend, and Gabrielle, I don't know if you could find this readily, but the main MHTTC website, I'll try to grab that now, is probably the best way to look for things like that. There doesn't tend to be a ton of national learning collaboratives because that would just be so huge. But on their website, you can find, you know, both your regional area and see if there's a center. Okay, someone already put it. Thank you, Gabrielle. And you can find your regional center. And there are a lot of resources around COVID on that site. And so when you go there, there's a whole bunch of responding to COVID with a variety of different topics there. So they've done a really nice job of just having a ton of resources, and a lot of things that have been happening since the pandemic hit have been reported. And so looking at that site is probably what I'd recommend the most right now, to sort of look at other opportunities or learning opportunities for things like that.